Now, let's move on to aneurysms. Now, aneurysm means dilatation of the lumen of the blood vessel. Typically because the wall has become weak and the pressure in the blood vessel allows the lumen to dilate, so now you have an increase in diameter of the blood vessel, okay? Now, our AV fistula, I'm going to talk about later on, just means you have a malformation of the blood vessels. And we'll talk about what problem you get into because of that, okay? But very important, with the aneurysms, we're talking about the wall is weak, allowing dilatation, and very important, it can lead to thrombus formation as well as rupture or dissection of the blood vessels. And we're going to talk about, again, the different types, and again, we want to do what? Compare and contrast the different types of aneurysms so you can pick out the right one on the exam. The first one we're going to talk about is the atherosclerotic aneurysm. Again, involving the abdominal aorta. Very important that the location is very important. So again, it's going to be what? It's going to be proximal to the bifurcation of the aorta at the iliacs and distal to the origin of the renal arteries, right? So very important. That's going to be the location of the aneurysm. Now, very important, this aneurysm may present as a pulsatile abdominal mass, okay? And that's why when you examine the patient in the abdomen, you do what? You actually auscultate first, and you can hear a bruit, because if you percuss first, you may rupture that aneurysm. That's very important. And again, you'll be in court saying, I promise to tell the truth, the whole truth, and nothing but the truth. So that's why it's very important in the abdomen, you auscultate first, then you percuss. However, though, after you auscultate the aneurysm and hear the bruit, okay, again, you might palpate lightly a pulsatile mass. Now, the patient may present also with back pain if the aneurysm erodes or is pressing on the vertebral column. So very important differentiation. If an elderly man has low back pain, it could be from a AAA, okay? Now notice here though, one of the problems we have associated with this is the fact that it may rupture, particularly if it's greater than 6 centimeters. So it's very important that the ones that are greater than 5, typically greater than 5, but definitely greater than 6, will rupture, and you have to worry about that because that can cause bleeding to the abdomen, and the patient actually can bleed to death. Of course, these patients also can get thrombosis of the aneurysm, again, and the thrombus can break off and become thromboemboli. They can go to the lower extremities, okay, so be aware of that. Now, as far as your locations of your aneurysm, very important, you notice here, they can be involving the abdominal aorta that we just talked about. That is classic for your atherosclerotic aneurysm. We're going to also talk about it in the circle of Willis. There's your Berry aneurysm, typically found around the anterior communicating artery of the circle of Willis. So that could be an anatomy question they may ask you. Again, there's a dissecting aneurysm we're going to talk about, typically seen in the ascending portion of the aorta as well. Now, let's move on and talk about our syphilitic aneurysm. Now, the key with this one is, you see here, also involves the ascending aorta or thoracic aorta. Very important is association with tertiary syphilis, okay? Very important is tertiary syphilis, okay? And the lesion you get, very important, is called obliterative endarteritis of the vasa vasorum. Remember, the aorta has a very thick wall, and the muscular wall actually needs its own blood supply. So remember that vasa vasorum actually supply blood to the wall of the aorta. So what happens is this obliterative endarteritis, or sometimes called endarteritis obliterans, same thing. What's happening is you're getting the inflammation which occludes the lumen of the vasa vasorum. Because of that, you get ischemia, and that leads to damage of the blood vessel, particularly the intima, and that leads to fibrosis. That fibrosis leads to the so-called tree barking appearance of the intima. That's classic for the step, tree barking of the intima, okay? So that's important. Also, because it involves the root of the aorta, you can get insufficiency of the aortic valve, okay? And because the regurgitation is so severe, the heart is very large, and a term you might see is called cor bovinum. Cor bovinum. What does that mean? That means cow heart. Cor means heart, bovinum means cow. And that's because of the severe regurgitation. The other important thing you want to remember, about this disorder is because of the scarring, you actually may get stenosis of the coronary blood vessels. Again, anatomy. Remember, the coronaries come off of the root of the aorta, okay? And again, because of that scarring, the patient may get stenosis of the coronary vessels, which could lead to myocardial infarction. So very important with your syphilitic aortitis, tree barking, tertiary syphilis, endarteritis obliterans, the vas vasorum, aortic valve insufficiency, cow heart, and the possibility of coronary stenosis, which could lead to myocardial infarction. Now let's move on and talk about our dissecting aneurysm of the aorta. Now, number one, it's very important to understand that this is actually a false aneurysm. In fact, what happens is the lumen does not increase in diameter, but you get a tear of the intima, allowing blood to seep into the media. And that's where the increase in thickness or widening of the aorta is seen. So very important, your dissecting aneurysm actually is a false aneurysm because there's no true dilatation of the lumen of the aorta. The key is you get an intimal tear, allowing blood to seep into the media, okay? They used to call this so-called cystic medial necrosis. Now they call it cystic medial degeneration. Again, because the blood goes into the media, okay? Now, very important, the patient will present with this so-called severe substernal tearing chest pain. And of course, you want to differentiate this from the chest pain you get what? From a myocardial infarction. So one of the key things you want to differentiate your dissecting aneurysm is your pain you get from that versus the myocardial infarction. Because remember, with your myocardial infarction, it's more of like a big pressure. Some people describe it like an elephant sitting on their chest, as opposed to this one, it's going to be severe substernal chest pain, and you get a history of the pain radiating to the back, as opposed to with the myocardial infarction, the pain typically radiates where? To the left side of the jaw, left shoulder, left neck. So very important, you want to make that differentiation. Now, very important too, with this disorder, there are two populations of patients can get this. One is going to be your 60 or 70-year-old male with a history of hypertension, and the classic history is going to be driving along, mind his own business, gets in an accident, his chest hits the steering wheel, and that causes the tear of the intima, and the hypertension forces the blood into the media. The other patient who gets this is a patient with what? Marfan syndrome, because Marfan's is a connective tissue disorder, and it causes the intima and the wall of the aorta to be weak, allowing the tear and the blood to seep into the media. So very important, your 60 to 70-year-old male with hypertension and your patient with Marfan syndrome is very important as far as causing or getting your dissecting aneurysm. So like I said, it's very important, as you see here, hypertension and Marfan syndrome, it's very important that the blood can seep into the wall, okay? Now, one of the key things you'll see on x-ray is so-called widening of the mediastinum. So very important if you see widening of the mediastinum, and again, that's because the blood seeps into the wall of the aorta, okay? So that is associated with dissection. So that's one thing you can see. The second problem or complications you can get are, number one, the blood can go through the wall and into the thoracic cavity, and the patient actually can bleed to death in their chest. That's one problem. The other problem is the blood can actually go into the wall of the aorta and track up the arch into the root of the aorta. That can lead to what? Cardiac tamponade. So very important that a dissecting aneurysm can lead to cardiac tamponade, and the patient actually going to have your so-called Beck's triad for cardiac tamponade, which is a JVD, muffled heart sounds, and your hypotension. So that's a very important complication of your dissecting aneurysm, okay? Now, like I said, also these patients will have the chest pain. You want to remember that. And again, remember that the blood goes into the media. Now, one thing you might see is that sometimes the blood will go into the media, track up the wall, and actually a second tear can occur, and the blood actually can go back into the lumen. This is a so-called double-barreled aorta, and actually this is good because it will protect against rupture through the wall and causing blood going into the thoracic cavity. So again, the so-called double-barreled aorta is associated with blood going from the lumen through the tear into the media, tracking along the wall, and then going back through another tear back into the lumen of the aorta, giving you the so-called double-barreled aorta. Let's now move on and talk about a couple of other important aneurysms you can get. One is the so-called berry aneurysm. Very important, like I said, found in the circle of Willis around the anterior communicating artery. So that's very important for anatomy. Very important is association with adult polycystic kidney disease. Okay, so I'll be aware of that. Now the key thing with this one is it can rupture. If it does rupture, it causes what? Subarachnoid hemorrhage. Okay, classic presentation. The patient will complain of the worst headache of their life. That's number one. Number two, because it involves the subarachnoid area, if you examine the CSF, it's going to look what? Bloody, or a term you might see is called xanthochromic. So very important, if you have subarachnoid hemorrhage from a berry aneurysm, they're going to have bloody or xanthochromic appearance of the CSF. Okay. The other one they might ask you about, of course, is the mycotic aneurysm. Now, by that terminology, you would think it's secondary to what? A fungal infection. In actuality, it's a misnomer. It's secondary to bacterial infection, particularly Salmonella and Shigella. Okay. Now, number one, they can come from the GI tract and cause this mycotic aneurysm. Another classic patient that gets mycotic aneurysm is your IV drug abuser. Okay. Sometimes you can see it where they inject the needle into themselves. You may also see it in the brain, that kind of thing. But very important, mycotic aneurysm is a misnomer. We're talking about bacterial infection rising in the wall, causing dilatation because the wall becomes weak. Okay. Now your AV fistula, very important. We're talking about a malformation of the arteries and the veins, and this can be associated with hemorrhage in the brain. Be aware of that. These can also form shunts, which can cause high output cardiac failure. I'll be aware of that. A typical place for that is like Paget's disease of the bone. Because of the new bone growth, you get these shunts that lead to high output failure, as you can see here, which we'll talk about in a little bit. Also can be associated with hemorrhage, like I said, particularly in the brain. And the hemorrhage can be intracerebral or actually may be subarachnoid in nature. So I'll be aware of those.